Hello, it's a pleasure to have the opportunity to speak with you today about pituitary disorders. My name's Ursula Kaiser. I'm the chief of the Division of Endocrinology, Diabetes, and Hypertension at Brigham and Women's Hospital and professor of medicine at Harvard Medical School. My disclosures are listed here. And I just wanted to take a moment to tell you about our learning objectives for today. This is a general review of neuroendocrinology. Our goal is to briefly review physiology, and then we'll spend most of our time talking about the approach and management of pituitary disorders. Um, this is an outline of my presentation. So as I said, I'll start with a brief review of physiology, then we'll talk about causes of pituitary disease, and then we'll focus on the approach to evaluation and management of pituitary disease, which I like to divide into three areas: assessment and management of pituitary hormone excess, secondly, pituitary hormone deficiency, and then thirdly, mass effects of pituitary disease. So we'll start by reviewing the pituitary gland. As you know, the pituitary is divided into the anterior and posterior pituitary. The anterior gland is actually glandular tissue and known as the adenohypophysis. It makes up the majority of the gland, about 80%, and it's derived from Rathke's pouch from the oral ectoderm during fetal development. It's comprised of 5 hormone-secreting cell types and secretes 6 hormones, which are controlled, the secretion of which are controlled by neuropeptides from the hypothalamus and by feedback from hormones from the target organs. The second part of the pituitary is the posterior pituitary, and it's known as the neurohypophysis because it's made up of neural tissue. It makes up the other 20% of the gland, and it's really a direct extension of the hypothalamus containing axon terminals from hypothalamic neurons. The hormones are produced in the hypothalamus, but then stored in the pituitary and released from the pituitary. So this slide, shows the physiology of pituitary hormone regulation. So on the left, we have the anterior pituitary. So the anterior pituitary cells are in the pituitary storing the hormones, the 5 cell types with the 6 specific hormones, which we'll talk more about. And they are released in response to hypothalamic stimulation by hypothalamic releasing neuropeptides, or their release is inhibited by inhibitory hypothalamic neuropeptides. Those pituitary hormones are then secreted into the circulation to act on distant target organs, like the thyroid or the ovary, for example. And those hormones then feed back both directly at the pituitary to modulate the pituitary hormone release and indirectly through the hypothalamus to modulate those neuropeptide secretion and thereby again regulate anterior pituitary hormone release. So these are classic endocrine negative feedback and positive feedback loops. The posterior pituitary, as I said, is neural in origin. So in the hypothalamus, we have the supraoptic and paraventricular nuclei where the neural cell bodies lie that produce the neuropeptides. The axons then project to the posterior pituitary where the nerve terminals sit and store the hormones. There are 2 posterior pituitary hormones: vasopressin, regulating water balance, and oxytocin, important for labor and delivery during pregnancy, and also the subject of a lot of interest these days. We'll be focusing primarily on the anterior pituitary during this lecture. So the approach to pituitary disorders is, as I said, I sort of divide this into 3 components, is to evaluate first for pituitary hyperfunction or oversecretion of any pituitary hormones. We do that by measuring baseline hormones and then in some cases also doing suppression tests. If you think there's too much of something, you test to see if you can inhibit it. And then secondly, pituitary insufficiency or hypofunction, again, measuring baseline hormones, or in this case, if we think there's not enough of something, we try to stimulate it with stimulation tests in some cases. And we'll talk more about these suppression and stimulation tests. And then thirdly is mass effects from a pituitary lesion itself. So with that background, I'm going to start with a case. This is a 39-year-old female who presented for pituitary evaluation of headaches. So she had headaches, and the question was whether it was related to pituitary disease that had been found on an MRI scan done for these headaches, which showed a 2 by 3.2 centimeter mass in the sella extending supracellularly up to the optic chiasm and into the left cavernous sinus. That's shown here on these MRI scans. So here's the normal pituitary shown here. You can see this in the sella turcica. You can see the normal concave upward pattern here, the pituitary stalk in the midline, and the optic chiasm above, just below the hypothalamus, with the third ventricle lying here and the lateral ventricles above. And here's this patient's adenoma. You can see it here. Here on the side, you can see the cavernous sinus, and on the other side, you can see that the tumor is actually invading the cavernous sinus and surrounding the carotid artery, which is this black dot. The pituitary stalk is deviated over to the right, and you can still see the optic chiasm preserved here, hypothalamus, ventricles. On the lateral, here again in the normal, you see the pituitary gland. The anterior pituitary is shown here. The posterior pituitary often shows up as a bright spot, and the absence of the bright spot sometimes is a marker of diabetes insipidus, although it's not a perfect correlation, so it's not entirely reliable. Here again, you see the pituitary stalk and the optic tract above it. And here is our patient with the adenoma. You can see it here. The pituitary stalk kind of shortened above it, the optic tract above that, and you can see some thinning of the sellar floor as the adenoma bulges downward into the sphenoid sinus. So just wanted to use this case to illustrate basic fundamentals of pituitary adenomas. And the first thing I want to say is not every lesion in the sella is a pituitary adenoma. It's certainly the most common, but you can also see other benign tumors like meningiomas, cell rest tumors like craniopharyngiomas or Rathke's cleft cyst or others, germ cell tumors, infectious and inflammatory lesions such as lymphocytic hypophysitis, which we actually are seeing much more commonly now with the advent of immune checkpoint inhibitors for treatments of a variety of cancers, and other granulomatous disorders listed here. We also can see metastatic tumors to the sellar and suprasellar region, vascular lesions like aneurysms, hematologic malignancies like lymphomas, and also empty sella syndrome and arachnoid cyst can appear as pituitary lesions. So pituitary adenomas are actually quite common. They make up about 10 to 15% of intracranial tumors, are present in about 15 to 20% of patients on MRI studies and autopsy series. So you may quite commonly have a patient who has an MRI for some other reason and an incidental pituitary lesion is found. These lesions are classified according to size, with microadenomas being less than 10 millimeters and macroadenomas greater than 10 millimeters. And this somewhat arbitrary designation is that because the smaller lesions are less likely to progress and enlarge and cause sequelae, whereas the larger macroadenomas are more likely to cause those complications. And adenomas can arise from any of the 5 hormone-secreting cell types: lactotropes, gonadotropes, somatotropes, corticotropes, and thyrotropes. And depending on their cell of origin, they can hypersecrete prolactin, LH and FSH, growth hormone, ACTH, or TSH. So when you're evaluating one of these patients, you want to ask questions to see if they might be hypersecreting any of these hormones. If ACTH, they might have symptoms of Cushing's syndrome. TSH, symptoms of hyperthyroidism. You can ask questions about growth hormone excess or prolactin excess. Less commonly do we see gonadotropin excess. More commonly, we see gonadotropin deficiency with hypogonadism. So you can see endocrine hypofunction of any of the axes as well. So you want to ask questions related to hypogonadism, growth hormone deficiency, hypothyroidism, and adrenal insufficiency. And then thirdly, you want to ask questions about the presence of mass effect symptoms like headaches and visual disturbances, and recall the sort of classic visual field deficit of bitemporal hemianopsia that occurs because of the pituitary lesion uh, abutting on the optic chiasm, just where these nerve fibers cross. But you can really get a variety of visual field defects, and it's important to work closely with a neuro-ophthalmologist to assess these patients. So our standard sort of pituitary lab testing is to test these various axes and to test the thyroid axis. Unlike in primary hypothyroidism, where you really only need to rely on the TSH, in secondary or pituitary hypothyroidism, you really need to look at the actual thyroid hormone levels as well and measure a free T4. To assess the reproductive axis, we measure a prolactin and FSH, LH, testosterone in men or estradiol in women. To measure the growth hormone axis, we really rely primarily on the IGF-1 level because growth hormone levels can fluctuate quite a bit. It's a very pulsatile hormone. And to assess the adrenal axis, we start with the cortisol, but look at ACTH as well. So we'll talk more about this, but it is critical to assess prolactin before proceeding to surgery because it's the one type of pituitary tumor where medical therapy is the first line of therapy. And then my second sort of take-home point from the slide is that if you are suspecting growth hormone excess or ACTH excess and Cushing disease, additional tests are likely necessary. So with that background, we'll move on to another case. This is a 27-year-old woman. She has 2 children. And then after 2 children went on birth control pills, but subsequently stopped them and her menses did not resume. On further questioning, she has some headaches, but no other visual or neurological complaints. She complains of some fatigue, some cold intolerance, feeling depressed. She can't seem to lose the weight that she gained with her last pregnancy. And she's had galactorrhea since stopping the birth control pills 6 months ago. She's on no medications, and just general physical exam is normal. But thinking some sort of questions to think about here are, what would you be looking for in an exam? And what would the differential diagnosis be here? So, with the galactorrhea, you might be thinking about prolactin. You'd certainly want to examine her to see if she has galactorrhea, because sometimes patients think they have galactorrhea, but it's actually not truly milk. It's just some crusting on the nipples. And you may also want to assess for adrenal insufficiency or hypothyroidism, given the fatigue and the cold intolerance and the depression. So here she's also had some lab results, and those results are shown here. And we'll just bring up a few discussion points about this case. And the first is the interpretation of these lab values. So starting here, we see actually she has a low estradiol level, and it's in the context of an inappropriately normal LH and FSH. And so this would suggest central or secondary hypogonadism, because if she had a primarily ovarian insufficiency, you would expect the LH and FSH to be high. Her IGF-1 is normal, suggesting that her growth hormone axis is intact. And cortisol is 8.2, which is a little bit sort of non-conclusive. Free T4 and TSH are normal. Her prolactin is quite elevated, 283, with normal being less than 23. So that's consistent with her galactorrhea. And her HCG is negative, which is always important to do in someone with a 6-month history of amenorrhea. You always want to exclude pregnancy. So what would you do next? You have this woman with hyperprolactinemia and hypogonadism. And what might you think the diagnosis is? And what would the treatment options be? So let's talk about more about some of these. So hyperprolactinemia is manifest as galactorrhea and hypogonadism. Those are the most common manifestations, with hypogonadism presenting as oligo or amenorrhea, as in this case, infertility in both men and women, erectile dysfunction in men, and hypogonadism can cause delayed puberty and delayed growth in children. Um, and if it's due to a pituitary tumor, there can be mass effect symptoms as well. So an important thing to remember is that there are many causes of hyperprolactinemia other than pituitary tumors, other than prolactinomas. Shown here is some of the normal physiology. Prolactin is somewhat unique among the pituitary hormones in that it's under primarily inhibitory input from the hypothalamus with secretion of dopamine from the hypothalamus to inhibit prolactin release. Um, it can also be stimulated by TRH, so can be elevated in hypothyroidism, which is listed on the differential, and can be stimulated by estradiol. And prolactin acts on the breast to stimulate prolactin secretion. And then, unlike the normal axis, there's no negative hormonal feedback, but there's a neurogenic feedback, which is activated by suckling or anything else that activates the chest wall to actually turn off dopamine and result in increased prolactin secretion. So remembering that physiology, we have the differential diagnosis here. Physiologic states like pregnancy or lactation, also stress and exercise can elevate prolactin modestly. A number of medications can elevate prolactin, so always important to review their medications. Hypothyroidism, as we mentioned, chest wall lesions, as we mentioned, also renal failure, cirrhosis, and seizures can be associated with mild hyperprolactinemia. Um, and then anything that damages the hypothalamic and pituitary stalk, because it will then inhibit this dopamine delivery and interfere with the normal inhibition of prolactin. So any lesion in the sellar or suprasellar region, like prior radiation, cysts, tumors, not necessarily prolactin secreting. And then the other main cause here is a prolactin secreting pituitary adenoma, prolactinoma. Sometimes we see prolactin with no clear explanation, so idiopathic. And then the last case is macroprolactinemia, which is always something to keep in mind, where the prolactin is an abnormal form with less biological activity, and the prolactin can be elevated, but without symptoms of elevated prolactin. So turning to treatment, as I mentioned, this is the one type of pituitary tumor that medical therapy is actually the first line treatment. And that's because we have very effective dopamine agonists that mimic the normal effects of dopamine to inhibit prolactin secretion, and they can actually shrink the pituitary tumor as well and decrease its size. So the two main ones that we use in the US are cabergoline and bromocriptine. Cabergoline is generally preferred because it has a longer half-life and fewer side effects. Dopamine agonists can cause some fatigue, lethargy, nausea, some lightheadedness because of CNS effects, but these two are not don't cross the blood-brain barrier very effectively, so they have fewer side effects than some other dopamine agonists, and that's why they're preferred. Surgery is second-line therapy if they're resistant to or intolerant of dopamine agonists. And radiation is generally reserved for only very aggressive tumors after surgery and medical therapy have failed. So shifting gears, we'll turn to another case. This is a 57-year-old male with multiple medical problems who recently presented with shortness of breath and chest pain and found to have a new onset of congestive heart failure and hypoxia. His past medical history is notable for arthritis, kidney stones, colon polyps, carpal tunnel syndrome, also gout and COPD, and he's on a number of medications that are listed here. And on physical exam, he's a little bit hypertensive. His extraocular movements and visual fields are intact. He has a large tongue and dentures. He has a moderate symmetrical enlargement of the thyroid with no palpable nodules. He has a few crackles and a positive S3. He's obese, and he's notable for having very large, doughy hands, shoe size of 13 wide, no active joint inflammation from his arthritis, and he has multiple skin tags. So hopefully this description is making you think of acromegaly, and we can talk more about what lab tests you would like. I'm not going to spend time on this slide, but I thought I'd leave it in here for you. Just it's a nice summary of the different clinical features of acromegaly. So let's talk more about his lab tests. And so here you can see that his IGF-1 is elevated. It's at 985. You need to look at an age and sex-specific normal range. His growth hormone actually falls within the normal range, and that's why the growth hormone levels can be so variable, and we don't really rely on a random growth hormone level. He has sort of a borderline low thyroid, free T4, and also a lowish TSH, so he may have some central hypothyroidism going on here as well. His testosterone is also low normal, and his prolactin level is normal. So still thinking about acromegaly with that elevated IGF-1. And so would you think about any radiologic tests at this time? Certainly you would want to get an MRI scan to see if he has a growth hormone secreting pituitary tumor. But let's talk a little bit more about the endocrinology. So we have this high IGF-1, but a normal growth hormone. If he had a tumor on the MRI scan, I think we'd be pretty convinced that he had acromegaly. But if you really wanted to confirm it, as I said, if you think there's too much of a hormone, you try to suppress it. And here, so what tests could you use to confirm growth hormone hypersecretion? You could do a midnight salivary cortisol, an oral glucose tolerance test for growth hormone suppression, urinary IGF-1, or a serum IGF-BP3. And the answer is a glucose tolerance test for growth hormone suppression. This is a 75-gram glucose tolerance test, just like you use for diabetes, but you measure growth hormone afterwards, and it should suppress at least to less than 1, and the cutoff may be even lower than that, depending on what assay your lab is using. So treatment for acromegaly, the first line therapy is still surgery, because surgery can be curative in this case. But we do have very good medical therapy with somatostatin analogs. Most of these tumors express somatostatin receptors. So we have 3 analogs available: octreotide, lanreotide, and pasireotide. All of which are available in long-acting intramuscular or deep subcutaneous once monthly injections, or every 4-week injections. And that's probably the most common. It actually targets the tumor itself. Cabergoline actually can also suppress growth hormone secretion. Many of these tumors express dopamine receptors and will be inhibited by cabergoline, particularly if they co-secrete prolactin, which we do sometimes see. And then pegvisomant is a growth hormone receptor antagonist. So it's very effective at normalizing IGF-1 and improving the symptoms and the manifestations of acromegaly, but does not act on the tumor itself, so does not result in any suppression of tumor growth. The somatostatin analogs can cause some decrease in tumor growth, but they're not as effective as the cabergoline is for prolactinomas, which is why in most cases we still prefer surgery as first line. And radiation is really now reserved for, again, very aggressive or resistant tumors. So our goal is biochemical cure to normalize IGF-1 and normalize growth hormone suppression in response to oral glucose. I briefly wanted to mention non-functioning adenomas. These usually arise from gonadotropes, but they appear clinically inactive because the tumors are very rarely are able to make biologically active intact gonadotropins. They're quite common. They represent about 1/3 of all pituitary tumors, and they often present with mass effect symptoms only because they, in most cases, don't secrete intact hormones. And so therefore, they often present with very large tumors and often with pituitary insufficiency. And we don't have any good medical therapy for these, so the treatment of choice is surgery. Just a few therapeutic considerations for pituitary tumors. You want to treat symptoms related to mass effects, restore or preserve vision, and improve any impairments in cranial nerves if there's cavernous sinus involvement or headaches. Our goal is to correct pituitary hyperfunction and then hormone replacement for hypopituitarism. So I've not talked about ACTH secreting tumors or Cushing's disease. That will be covered in the adrenal lecture in this course, and also not in the TSH secreting tumors, which cause hyperthyroidism with a non-suppressed TSH. They're quite rare, so we'll not spend more time talking about those. I wanted to just spend a minute or two talking about perioperative management for any of you who might be asked to consult on these patients in the hospital. Preoperatively, ideally, it's good to try to replace any deficiencies, particularly cortisol, glucocorticoids, and also thyroid if they're very hypothyroid, or at least let the anesthesiologist know so that they can adjust their anesthesia medications because of the delayed clearance in hypothyroidism. During surgery, they may need stress dose steroids, and then in the early inpatient postoperative period, you want to assess them neurologically. You want to look for diabetes insipidus or SIADH in this early phase, and also for adrenal insufficiency, and treat with glucocorticoids if it's present. After discharge, we usually evaluate them again a week postoperatively to look at their water balance, serum sodium, and assess again their adrenal axis. And then at 6 weeks to now assess for any delayed evidence of pituitary insufficiency, since hypothyroidism can take a little longer to become manifest. And then at 12 weeks again to reassess their endocrine status, and also that's usually when we do an MRI scan to serve as a new baseline. And then subsequent follow-up annually or more frequently depending on their clinical status, and also to look for recurrence in the long term. So a few words about hypopituitarism or pituitary deficiency. The treatment is based on correcting hormone deficiencies. So adrenal is the most important, and replaced usually with hydrocortisone, or in some cases prednisone, if single once a day dosing is needed, if patient can't do twice a day dosing. You may need to do stimulation testing to diagnose adrenal insufficiency, secondary adrenal insufficiency. And it's important, again, to review with them sick day dosing and stress dose coverage for acute illnesses or emergencies. And mineralocorticoid replacement is not necessary since aldosterone will still be produced. It's ACTH, relatively ACTH independent. For replacement of the thyroid axis, we use levothyroxine after assessing and replacing with hydrocortisone if needed. And it's important to remember in these patients that TSH can't guide your therapy, so we target to a free T4 level in the upper half of the normal range. For gonadal replacement, we use sex steroids, testosterone in men, estrogen and progesterone in premenopausal women to protect bones and provide them with the normal estrogens. If fertility is desired, they will need gonadotropin treatment. And for growth hormone deficiency, most insurers require stimulation testing. And if they have documented growth hormone deficiency, we do have recombinant growth hormone available. Prolactin we don't replace. And for posterior pituitary, its focus is on the vasopressin axis, treating with DDAVP. So just to summarize, take-home message, in evaluation, let physiology be your guide. Evaluate for hyperfunction, as we've discussed, hypofunction, all hormone axes, and mass effects. And treatment is aimed at restoring normal pituitary function and can include surgery, hormone replacement, and medications targeting hormone excess. So lastly, I'd like to close by working through a couple of additional cases. These ones are in the form of questions for you to work through. So the first case here is a patient who presents with increasing ring and shoe size and changes in appearance as noted by her family. You suspect that she may have acromegaly. Which of the following tests is most helpful in establishing the diagnosis? A, pituitary MRI scan. B, insulin tolerance test with growth hormone levels. C, serum IGF-BP3. Or D, oral glucose tolerance test with growth hormone levels. So the correct answer is D, oral glucose tolerance test with growth hormone levels. As you'll recall, we talked about how if you think there might be too much of a hormone, you try to suppress it. And the most specific test for establishing the diagnosis of acromegaly is an oral glucose tolerance test. In normal subjects, serum growth hormone concentration should decrease to less than 1 nanogram per mil within 2 hours after ingestion of 75 grams of glucose, a standard oral glucose tolerance test. You need to check with your own lab. As we discussed before, some labs may have a lower cutoff than 1 nanogram per mil, depending on what type of assay they're using. In contrast, usually the levels of growth hormone after glucose remain greater than 2 nanograms per mil in over 85% of patients with acromegaly. So just to sort of think about the other possible answers here, a pituitary MRI scan would certainly be helpful in terms of determining if there's a pituitary lesion, but it does not assess whether there's any hormonal changes. It's purely a structural test. An insulin tolerance test with growth hormone levels is used to try to stimulate growth hormone, is used as a test for growth hormone deficiency, not for growth hormone excess or acromegaly. And a serum IGF-BP3 is not so helpful in diagnosing acromegaly in adults. Certainly a serum IGF-1 might be very helpful here. Some pediatricians use an IGF-BP3 in conjunction with an IGF-1, but it's less useful in adults. So the best answer here is answer D. So one additional question for your thoughts and consideration. This is a 32-year-old woman who presents with a 6-month history of irregular periods. Instead of her usual cycle of 28 to 30 days, her periods have been 6 to 8 weeks apart. Further questioning reveals that she's also noted a bit of milky fluid on her nipples on several occasions over the past few months. A serum prolactin level is 95 nanograms per mil, with normal being between 2 and 16. Which of the following is not likely to cause hyperprolactinemia? A, non-functioning pituitary macroadenoma. B, a prolactin-secreting microadenoma. C, therapy with L-DOPA for Parkinson's disease. D, therapy with antipsychotic medications such as risperidone. Or E, primary hypothyroidism. So the correct answer is C, therapy with L-DOPA. So L-DOPA crosses the blood-brain barrier and is converted to dopamine in the central nervous system used to treat Parkinson's disease. And dopamine, as we discussed, inhibits prolactin secretion and can actually be used as a treatment for hyperprolactinemia. So in contrast to this, pituitary macroadenoma can compress the pituitary stalk and interfere with delivery of endogenous hypothalamic dopamine to the pituitary, resulting in hyperprolactinemia. Prolactin can be secreted from a microadenoma, causing hyperprolactinemia with resistance to the endogenous hypothalamic dopamine. Antipsychotic medications can block the dopamine receptors, therefore resulting in hyperprolactinemia. And hypothyroidism through the increase in TRH can stimulate prolactin secretion and cause mild hyperprolactinemia. So in closing, I want to thank you for your attention, I have added some references for some additional reading behind some of the content, as well as some of the areas we didn't cover as much, such as Cushing's syndrome and Cushing disease. Thank you very much for your attention.